Dear colleagues, my name is Armand Gerbes. I'm an intensivist and clinical pharmacologist and chair of Department of Intensive Care in Amsterdam. I have no potential conflict of interest to declare related to this topic. I will talk with you about the limitation of randomized controlled trials in the ICU, which are, in my opinion, still not sufficiently acknowledged. But there is hope. I saw this recent paper published in Cardiac Failure Review, where the authors indicate that they fully agree with the paper that we have recently written on this subject, Time to Stop Randomized and Large Pragmatic Trials for Intensive Care Medicine Syndromes. So that gives me a lot of hope. And this message that I have may seem unpleasant, of course, for trialists, but I can tell them that they should not worry, because we really do need randomized controlled trials also in the ICU. But we need to acknowledge the limitations. And we also have to acknowledge that we did a lot of nonsense randomized controlled trials. And this, you see here, the paper that we recently wrote, a study that we recently did, the effect of small versus large clock size on emergency response time and randomized controlled trials. I recently received the proofs, and I hope by the time that you see this presentation that you can see the paper, and please read it. There are many randomized controlled trials in the ICU for mortality, and they fail to demonstrate any difference. And the randomized controlled trials that do show a difference are mostly related to the fact that there is a very high mortality in the control group. And we published on this, and as you can see here, you see that the control group mortality in the positive trials, the control group mortality was rather high, 50%, and this is for septic shock. And in the negative trials, where there was no difference found, it is much lower. Whereas in the if you look at the intervention group mortality, there seems to be no big difference between. So if you look at this figure, you can see that when you look at the control group mortality, when it increases, that is also a higher probability of a positive trial. And there is, of course, a recent example of this. You're all aware of the dexamethasone study on COVID-19 hospitalized patients. And as you can see here, in the patients who were mechanically ventilated, the mortality is up to 40% at 28 days in the control group. And we did an inventory on the numbers in the Netherlands and also, of course, in our own ICU of approximately 100 patients. And the mortality is much lower and goes to approximately between 20 and 25%. So this makes you think about what is the external validation. So why do we mostly see no difference? When you start a randomized controlled trial, you have a disease, and the disease, there is a mortality that is caused by the disease, and then you do an intervention, and then what you hope that it acts on the disease, and there will be a difference in mortality. And this is, of course, true for something like this, like testicular tumors, as you can see here, where in 1973, the outcome was really very bad, and within 2 years, all patients, in fact, died. And as we look now in 2020, the 10-year survival is as high as 94%. And this is all thanks to the studies, the randomized controlled trials that have been performed. But this is a very clearly defined disease in otherwise healthy young men. Now, intensivists, they work with syndromes like acute kidney injury, ARDS, sepsis, septic shock, and delirium. And these syndromes, to talk about syndromes, of course, very useful in clinical practice. When you tell the nurse, we will have a patient with ARDS, she knows exactly what to prepare. And syndromes is, in fact, a grouping of clinical phenomena in labels. But we talk, in fact, about multifactorial disease processes. We published this paper approximately 2 years ago, Unexplained Mortality Differences Between Septic Shock Trials. And we looked at the mortality rates of the control group, and it varied from 14% to 85%. And there was a significant heterogeneity among the trials. If you look at the number of exclusion criteria, you can see the more exclusion criteria there were, the lower mortality. I found it myself very funny, but perhaps you think it's only very logical. These were all the trials that we looked at, and you can see here the mortality that goes up to 60% as a predicted mortality. We calculated the predicted mortality, and you can see there are a lot of trials that had a very much higher observed mortality than the predicted mortality. And I can tell you also, these were in fact the trials that were most likely to be positive in terms of a difference between the control and the intervention group. Now, the treatment effects can be very different for the least severely ill patients or for the most severely ill patients. And you're probably aware of the importance of the attributable risk. And I will go with you with an example of a hypothetical syndrome. I call it the H syndrome. There is a 35% mortality rate, and there is a new intervention that reduces harmful sequelae. And we can do something that gives a 20% relative risk reduction, which is a 7% absolute risk reduction. And then you can very easily calculate that you need approximately 1,400 patients. And this seems all very reasonable to you, I presume. Now, the forgotten fundamental question is, which proportion of the mortality risk is attributable to the critical illness H syndrome? And I think you will agree with me that if it is less than 20%, there cannot be a demonstrable effect. So critical care syndromes are associated with the underlying severity of illness. Sicker patients have acute kidney injuries, sicker patients have ARDS, and sicker patients have septic shock. Now, the attributable risk is nothing new, in fact. This is a paper from 1978 where it was already highlighted, and relatively recently, Manu Shankar also published on this, and he calculated for us the attributable risk of sepsis, and he estimated it to be as 15%. And I will explain to you that this is very, very probably an overestimation. So therefore we did a computer simulation example, and that's now very easy. You can create 4,000 patients and give them a median mortality risk of 7%, a very heterogeneous mortality. A risk of the H syndrome correlates to the baseline mortality risk. But the H syndrome does not cause an increase of mortality. So the attributable mortality is 0. So what you then see is what you expect is here you see the number of patients, and you see a lot of patients who have a low risk of mortality and a very low number of patients who have a high risk of mortality. And it is depicted in this figure. You see here 4,000 dots. And in the red one, the syndrome is present, and in the blue one, the syndrome is absent. And as you can see, the higher the mortality is, the more red dots you see relatively, as explained before. Now, if you look at the mortality according to the severity score, and then you will find, of course, that if the syndrome was present, the mortality was much higher than when the syndrome was absent. And this is, you say, well, this is quite common. So what you do normally is that you do a severity score matching. And this is an area under the receiver operating characteristic of 0.84, which is in fact quite high. And you see that the matching is perfect. And what we see, to our surprise, is that there is a difference in mortality in the absent syndrome absent patient and the syndrome present patients. What we would not expect. And there seems to be something like 15% attributable risk. Now, how come? So we thought about that. What is the possibility? So what we did is we made another severity score, a near perfect characterization, and we matched the patient again. And this severity score had an AUC of 0.88, which is higher. And so it's more precise, as you can see here. And then what we saw is that at that moment, there is no difference anymore of the mortality rate, as we instructed from the beginning. We created our own patients. So why is this failure? And another important factor is that our model is simply too simple. And it's much more complicated than we think. As you can see here, is you have a disease that can go to death, and there is a syndrome-independent mortality risk. This can be acute kidney injury, ARDS, etc. And this is the attributable mortality risk. Now, let's suppose that we have, as in the example, that we have a sample size that is needed for 35% control mortality. So if we want a 30% relative risk reduction and the attributive risk is 100%, as you can see here, 1, then you will need approximately 700-800 patients, as you can see here. But if the attributable risk is smaller, for instance, 0.25, all of a sudden we will need more than 10,000 patients. Or if it's even lower, we need more than 32,000 patients to find a 30% relative risk reduction. So what needs to be acknowledged is the role of the high mortality in the control group that we see when we look at randomized control trials that are published, the role of unmeasured important characteristics, as I showed you, and the failure of understanding the disease, and the attributable risk is much lower than you think, as I indicated with these data I just have shown to you. So I thank you very much for your attention. Stay healthy and see you next time.